Treatment of differentiated thyroid cancer. Surgery for differentiated thyroid cancer. Mayo Clinic has been observed the treatment of DTC since 1940, and 70% of the patient DTC in 1940 underwent unilateral lobectomy, and by 1950 this rate decreased to 22%, and by 1960 only 5% of patients of the DTC underwent unilateral lobectomy. So in contrast, 1980 total to near total thyroidectomy was performed in 92% of the patient with DTC, and the current day practice is most thyroid nodule more than 4 cm with DTC undergo either total or near total thyroidectomy as preferred clinical treatment, whereas lobectomy is considered for tumor which are 1 to 4 cm in DTC without any high risk feature. So preoperative ultrasonography of the neck allow evaluation of the suspicious neck node metastasis (NNM), and that should be resected with a modified neck dissection at the time of initial thyroidectomy. And of 1900 patients undergoing primary surgery for PTC at Mayo Clinic from 1940 to 1991, 23% patient had a suspicious node by palpation, and more than 50% of the patients, those with a PTC, had nodes removed at surgery, and 38% had node that were positive for metastasis, and only 4% of the patient with FTC and 6% of the patient with Hurthle cell carcinoma, they have a neck node metastasis and at initial evaluation. And 2000 patients of the DTC who underwent complete surgical resection in Mayo Clinic. 8% this nodal recurrence occurs in 8% in PTC, 2% in the FTC, and 18% of the Hurthle cell carcinoma by the age of 20 years. And the therapeutic neck dissection is performed in initial thyroidectomy for patient PTC with neck node mets, and prophylactic neck dissection is not recommended. Prophylactic neck dissection is not recommended. However, prophylactic neck dissection remains controversial, and at Mayo Clinic we routinely dissect the central compartment neck nodes at the initial thyroidectomy. And cancer contrast and CECT is indicated for patients with locally advanced disease or vocal cord paralysis. And the conventional open thyroidectomy approach is standard for thyroid cancer. However, due to cosmetic and other concerning like neck scar, non-conventional approaches have been like minimal invasive video assisted thyroidectomy, robot assisted transaxillary thyroidectomy, and transoral endoscopic thyroidectomy with vestibular approach are being explored, and these approaches are still need to be validated in high volume centers. Now, what is the role of adjuvant therapy for differentiated thyroid cancer? And in 2015 ATA guideline, they recommended a TSH level of 0.5 to 2 milli international unit per liter and acceptable for DTC patient at low risk. Who are at low risk, then FSH level of 0.5 to 2 milli international unit is acceptable, and TSH level of 0.1 milli international unit per liter to 0.5 for intermediate risk group, and FSH level less than 0.1 milli international for high risk patients. The duration of follow-up increases structural and biochemical like thyroglobulin level that should be weighted against the cardiovascular osteoporosis risk of FSH suppression. At Mayo Clinic, approximately 60% of the patient who underwent radioactive iodine ablation within 6 months of initial surgery in 1980, and this is in comparison to only 6% in 1970. Analysis of 1163 patient at Mayo Clinic with low risk of PTC like Massey score 6 between 1970 to 2000 showed no difference in 20-year tumor recurrence and cause specific mortality between patients who received surgical treatment alone versus those who received surgical treatment with radioiodine ablation. And the studies did not show improvement in recurrence and cause specific mortality in patients with low risk disease. So it has become clear that radioactive iodine ablation in low risk DTC does not change long term outcome. And as per the ATA stratification, radioactive iodine adjuvant therapy that is indicated for high risk patient and in some those with the intermediate risk recurrence, but not for low risk patients, not for low risk patients. So post-operative radioactive iodine ablation adjuvant therapy typically performed approximately 6 weeks after total thyroidectomy, approximately 6 weeks after 6 weeks after total thyroidectomy, to optimize both the normal residual thyroid and thyroid cancer. TSH must be more than 30 milli international unit per liter, which can be achieved by rendering patient hypothyroid, and also recommended that the serum thyroglobulin level obtained during hypothyroid period, and a low iodine diet like 1 to 2 weeks before scanning or with iodine 131 to enhance the uptake and retention of the radioactive iodine. Alternatively, imaging and treatment using FSH stimulation with recombinant human TSH performed for increased frequency, and this method is preferred rendering if the patient is frankly hypothyroid is potentially hazardous, such as patient with a metastatic PTC with central nervous system involvement. And post therapy whole body iodine is typically performed after post therapy whole body iodine scanning is performed after 1 week of iodine 131 treatment to identify any metastasis. And the most common side effect of the radioactive iodine is silidinitis, nausea, and temporary bone marrow suppression. And the woman undergoing iodine 131 treatment should be advised to avoid pregnancy during 6 to 12 months and after treatment due to risk of miscarriage, and there is fetal malformation, and there is a weak but dose dense relationship between iodine 131 therapy and the development of the second malignancy and potential reduced ovarian reserve.